Yeah, thank you very much for this kind introduction. Thank you, Manos and Manos, for this really great event meeting. It's always a pleasure to come here and talk. So when we talk about AC joint, and especially I only got to talk about one specific type 3 AC joint injuries. I just looked back, I had a talk on this on the online version of the conference in 21, and it's probably a complete different talk because scientific manners have changed in the last couple of years in regards to this topic. I have nothing to disclose. So when talking about AC joint, then we have always to consider the anatomy of this specific joint. It's pretty small, but has a high grade of motion and a high grade of stability as well, which is pretty unique. And in order to understand this joint, we have to actually look quite far away from this joint to the triangle of the shoulder, including the scapula as well, in order to really understand its function. So when we talk about the Rockwood classification, this is a picture almost 10 years ago in the German Society, where they asked 220 surgeons in regards of what they would do for a specific Rockwood classification treatment. And it was pretty obvious that type 1 and 2, everybody would consider non-operative treatment, and 4, 5, and 6 were predominantly operative treatment, but there was always the lack of evidence for type 3. The majority of the surgeons actually did opt for surgical treatment, however. But we do have problems when talking about classification system, and it first starts in how to classify. So this is a standard AP X-ray taken in an emergency department, and this is where it actually starts. So when you look at the pictures, can anybody tell which one of those right shoulders has the greater AC joint instability? So obviously it looks like it should be the left one, right? So let's go into this, and this one is the right shoulder we just saw on a bilateral image, and we could definitely see that there's a difference in the CC distance on the right side. So, which would make it a type 5 Rockwood classification. Whereas we will look on the other one, which on the AP shoulder X-ray looked quite obvious in type of instability. When we dig a bilateral image, there's actually not much difference in the CC distance, because this difference is mainly due to posterior shift on the horizontal plane. So by definition, this would be a type 4 kind of Rockwood classification and not 5 or 3. So my go-to images, and this is something we learned in Munich and try to practice this as well as we can, is bilateral unweighted X-rays is my standard for all AC joints. There's no necessary for any weight. Actually, there's a couple new studies that suggest when you use weight, you overestimate the injury, and all the Rockwood classification was done without weights, so do not use the weights. And then I always add functional imaging on both sides, meaning an axillary view, to at least get an idea of the horizontal instability. So, when we talk about AC joint, and especially the type 3 injuries, I consider that the AC joint is something like another force couple of the shoulder. So we have something in the front and we have something in the back, and both of them need to work in order to have a function of the shoulder. Otherwise you get less range of motion, you get pain, and you have less strength for your rotator cuff. So we do know that scapulothoracic function is the key to success for all AC joint injuries in no regards to the stage or the degree of instability. We do know that scapular dyskinesia is a quite common problem, especially in the type 3 and in the chronics, and they are much more important for the functional outcome if there's a scapular problem. So we do have somewhere around the mark of 6 weeks in order to see if the patient actually profits from our treatment or not, and this is the matter that we need the 6 weeks in order to really get a good idea and understanding of what treatment would be the best for this patient. Another thing that we see now is that the CC distance is dependent on position. So we now also see that in arthroplasty, where we actually look for the scapular position on the back of the patient. And we do see when patients have a high scapular tilt on the backside of the shoulder, they have an increased CC distance and a less likelihood of recover their scapular position. Just to show you this in a clinical example, you can reposition the AC joint just by pushing on the backside of the scapula in order to reposition or retilt the scapula, and this is also something to decrease the CC distance, and it's important for the scapular function afterwards. And then we have a little bit of literature on the AC joint, and especially for the type 3 injuries that got recently published. So first of all, this is one of the biggest ones with a level 2 study, type 3 and type 5 non-operative versus hook plate surgery. They found that there's no difference in functional outcome between the two groups. However, when we discuss studies like this, we have to be also going into the details. They do not look for specific AC joint scores. The hook plate may not be the first choice treatment in our hands anymore. And we have an 18% crossover rate, means 18% of the patients that were designed for the non-operative treatment arm crossed over into the operative treatment arm and may have changed the results. However, we do see really good results 2 years after non-operative management of AC joint injuries. The next one is level 1 study. So we have actually level 1 evidence that a non-surgical treatment option is as equal, if not superior, to a surgical treatment. So this would make us really hard and arguing nowadays for opting first-line choice of operative treatment for an AC joint type 3 injury. Especially when we look after that slower recovery time and higher complication rate for operative treatment. We do know now that pain seems to be a factor for the success of this treatment. So if there's a painful AC joint after 7 days after the injury, and this study group marked this with a VAS score of larger than 7, they were less likely to recover non-operatively and switched over to operative treatment. So we do have a shifting in recommendation. We now see much more chronic AC joint injuries in comparison to the acute ones for secondary surgery opinions. And how to treat when we talk about non-operative treatment is something that is now of interest. So there's a specific brace now for the AC joint. I don't know if it's available in your country, but for us there's a brand that offers now a AC reduction brace, and this group compared it with just a standard sling, and they could found no difference 1 year after treatment without differences in radiological differences or clinical scores. Nevertheless, there are this kind of patient that need surgical treatment afterwards. Peter Millett shows us in the patients, or in a study of his, that 41 of non-operative treated patients with the 12% of failure rate after somewhere around the 6 weeks marks. And then he figured the longer they wait to start the non-operative treatment, the less likelihood they were to recover. So if we talk about conservative treatment, then we have to know the treatment. It's not wait until the surgery starts. The treatment is actually the non-operative treatment in the physical therapy. And this is a really great paper that I can recommend to every surgeon that writes prescription for physical therapy. He actually should know what they should do in the physical therapy and not just do something. This is a really great paper by Ben Kibler's group with a lot of pictures and actually shows what kind of workouts should be done at what time period. So overall, we're still using the Rockwood classification for now, which I don't think is the best classification, but we don't have any other. It does not include anything like the scapula. It does not include anything like pain or function of the shoulder. We're only looking at x-rays. However, if we would ask the German Society again, I'm pretty sure that the Rockwood classification, especially the type 3s, would be much more conservative and much more non-operative treatment by now. So my conclusion for the key of success for a type 3 injury is a pain and scapular control seems to be the factors for further scientific assessment and may be used for future classification systems. I do believe that correct imaging and clinical evaluation is the key to success for this type of injury. First choice of treatment will be now, for me, non-operative treatment. However, conservative treatment strategies need to be really clear and reproducible for all the physical therapists out there. And I do think that a reassessment for treatment failure is very important, and you need to follow up your patients in order to really treat them well. Thank you very much.